Hello, and welcome to the latest episode of Inside 340B Report. I'm Ted Slafsky, publisher and CEO of 340B Report, and I'm joined today by Will Newton, an associate editor and senior writer at 340B Report. Shannon Young, our other associate editor and senior writer, is out of the office this week, but looks forward to joining us for our next episode. Before we dive into the latest 340B developments, I want to let our listeners know that we're pleased to offer a special 25% discount to 340B Report first-time subscribers. You can go to the subscribe tab at 340breport.com and use the coupon code podcast25 to take advantage of the discount. I know you will find our news service to be a valuable investment. Also, I want to encourage you to check out our new business area podcast hosted by a longtime colleague of mine, Anna Mangum. The name of the podcast is 340B Leaders Up Front. In the latest episode that just went live the other day, Anna interviews two of the leaders of Plentiful, an AI service provider company that's providing very cost-effective and highly beneficial services for the 340B provider community. So check out 340B Leaders Up Front, wherever you get your podcasts. Today, we're going to hear a quick update from Will on the latest on the controversial 340B rebate pilot program and surrounding litigation. Next, we'll discuss the growing trend of geographically urban hospitals reclassifying as rural under the Medicare program, and why some rural health advocates are worried that this will bring unwanted scrutiny on the 340B program. Finally, we're going to take some time to celebrate the life and legacy of the late Sue Veer, a nationally recognized community health center leader and one of the 340B program's most respected voices and influential advocates and educators. I'll be joined by a special guest, Colleen Meiman, who was very close to Sue, to try our best to put words to Sue's incredible legacy and the deep sense of sorrow felt by all who had the privilege of working with and knowing her. But before we get to my conversation with Colleen, we're going to start by hearing about some key 340B developments. Will, can you tell us the latest in the 340B rebate battle?
Yeah, definitely, Ted. And before I get to your question, just wanted to quickly say that I'm really looking forward to hearing your conversation with Colleen later on in this podcast episode. I know that Sue left a really incredible legacy on everyone she worked with and all of her close friends. So I know that that will be really moving. And for now, to answer your question, yes, there have been some pretty significant developments in the 340B rebate saga, and specifically the drug industry's efforts to convert upfront 340B discounts to a post-purchase rebate model. As some quick background, the biggest development was that HRSA, the Health Resources and Services Administration, which is the federal agency overseeing 340B, at the very end of July announced a very controversial 340B rebate pilot program. Under this pilot program, manufacturers of the 10 drugs subject to the first round of Medicare drug price negotiations are able to submit rebate proposals to HRSA for approval if they meet HRSA's specific criteria, and those rebate models would take effect in 2026. Now, the drug industry has been arguing and pushing for much more expansive rebate models than this, but providers have been pretty united in strongly opposing any efforts to convert the 340B program to a rebate. They've argued this would upend more than 3 decades of precedent and put some pretty significant financial burdens on already strapped healthcare providers that would really impact their ability to serve vulnerable patients. And that's really where we were in last episode. The developments that have happened since then is that HRSA recently came out with an FAQ in response to a ton of questions the agency was getting from stakeholders that tried to clarify a few things. One of the things HRSA said in this was that, yes, the 340B rebate pilot only applies to 10 drugs in 2026, but it did say that HRSA could expand this to more drugs in the future. The FAQ also clarified that if a manufacturer is not consistently paying rebates in a timely manner or cooperating with covered entities, then HRSA could revoke their participation in the pilot program. But, 340B providers are still very, very concerned about this and very opposed to this model altogether. And the American Hospital Association recently sent HRSA a letter basically asking the agency to abandon the rebate pilot altogether. The Hospital Association was arguing that the rebate program is basically a solution to a problem that doesn't really exist, or at the very least was manufactured by the drug industry. The American Hospital Association also noted that, yes, it looks like HRSA is pretty set on moving forward with this pilot. So the Hospital Association said, if you are going to do this, we really, really urge you to put more guardrails in place to ensure that the drug industry doesn't abuse it. And the overall deadline for stakeholders to submit feedback on the rebate proposal is September 8th. So we expect to be seeing a lot more criticisms from providers and suggestions from providers. And it'll be interesting to see what the drug industry says as well. So we'll be very closely following that. And then the final update, which is happening separately, but at the same time as all of this, is there is active litigation in which drug makers are arguing that HRSA does not have authority to approve rebates and that drug makers should be able to implement any rebate for any amount of drugs without needing HRSA's approval. Several drug makers sued the government at the very end of last year and the beginning of this year, and 2 federal district judges earlier this year ruled against them and said, yes, the government does have the authority to choose whether or not rebates can proceed and also the authority to reject them. These drug makers have since appealed, and a federal appeals court in Washington, D.C. is actively overseeing a consolidated appeal with several drug companies. The big development there is that the court has recently kind of extended the whole deadline for everything. So the court pushed back 1 week the deadline for drug makers to make their opening brief and filing, and also agreed to postpone oral arguments, which were originally scheduled for October 23rd. Basically, what happened there is that 340B Health, which is a hospital trade group intervening in the case, notified the court that its lead attorney wasn't available that date, so the court agreed to postpone it, and we're waiting to hear where the new date is then. And so overall, what we have is, on the one hand, HRSA's rebate pilot program that is pushing forward ahead, and then on the other hand, this federal appeals court case about HRSA's authority over 340B rebates in the first place. So those are 2 areas that we're very closely following, and we'll continue to update our listeners and readers on any other major updates there.
Well, I'm be very curious to see what other stakeholders tell HRSA as the comments start to come in. I was actually surprised that AHA got their comments in so quickly. I think it underscores how concerned they are about the rebate model, that they would submit it a few weeks prior to the deadline. And it will be interesting to see what the other organizations have to say, both from the provider and industry perspective. So thank you for that good coverage, Will. You recently attended a conference in Louisville, Kentucky, focused on rural healthcare provider issues. And you wrote an interesting piece about a growing hospital reclassification trend that has some rural health advocates concerned. Can you tell us more about that and its 340B implications?
Definitely. This whole thing really goes back to this new government rule that happened in 2016 or 2017 that basically allowed urban hospitals to duly classify as both urban and rural under the Medicare program. And what that means is that these urban hospitals could classify as urban in order to get higher urban wage indexes under Medicare, while at the same time classifying as what's known as administratively rural in order to get other benefits that were intended for rural providers. These other benefits include enhanced Medicare reimbursement, access to some more graduate medical education slots, and also a lower eligibility threshold for the 340B program. This trend has been going on for several years now, and it started to get a lot more scrutiny and attention after this health affairs article came out earlier this month. And the main finding there is that in 2017, right around the time of this rule change, there were about a dozen hospitals that were duly qualified as both rural and urban under Medicare. Now in 2023, there were over 400. So there's been a huge surge. And the finding also found that a lot of these hospitals that are duly qualified as urban and rural are based in large US cities. And that's been attracting some scrutiny. I spoke to a number of rural healthcare advocates, and basically they were saying that there were some concerns that if these urban hospitals that are geographically urban are have this rural status under Medicare, that they could be competing for resources that are intended for rural providers, and in some cases there's a pretty limited pool. For the 340B program, there's also some slightly different concerns. If an urban hospital is able to qualify for 340B more easily as a rural referral center with a lower eligibility threshold, that does not affect rural providers' ability to qualify for 340B. So it's not necessarily a zero-sum game there. That said, if there is more attention and negative attention on the 340B program, as has been the case after this health affairs article, there are some concerns that this could have negative impacts for everybody in the 340B provider community. And we've already seen that some opponents of the 340B program, including the drug industry and some key politicians, are already looking at this article and using this to call for some broader reforms. So I think a lot of healthcare advocates, and specifically rural healthcare advocates, are concerned that critics of the program will capitalize on this big trend of urban hospitals qualifying as rural in order to push for reforms that would hurt the entire provider community. That's a really pretty interesting trend and some interesting feedback. And we did a big article on that. So at the same time that all of these bigger issues in 340B are happening, it will be certainly really interesting to follow this and see how that affects the various legislative proposals for 340B reforms.
Yeah, I was going to say, Will, has there been any reason or reaction from any of the hospitals explaining why they may qualify? Could it be because they're, even though they're in a city, they're close to a rural area? Just curious if they're, what are some of the arguments perhaps for why someone would qualify in both rural and urban status?
Basically, what happened is CMS, the Centers for Medicare and Medicaid Service, for a while had a rule in place that said that if you qualify as an urban hospital and have the higher urban wage index under Medicare, then you're not allowed to also qualify as rural and get benefits that are designed for rural providers, basically saying you can have one status or the other, but you can't have both. And so while that was in place, urban hospitals were just keeping their urban status. Then there were two federal court cases that challenged this. And the result was basically that CMS did not have the direct authority under the statute to issue this rule that said you can't do both. So as soon as those court cases happened, then more hospitals, seeing that they had ability to, get higher Medicare urban wage indexes and also higher Medicare reimbursement and lower 340B eligibility, began taking advantage of this and increasingly becoming dual eligible. So that those court cases are really what prompted this surge that we've seen recently.
Oh, that's interesting. As I reflect on this issue, it comes at a difficult time for the hospitals where, as you've been reporting, many of them are likely to lose 340B eligibility with the cuts in the number of Medicaid patients that will be in that program in the coming years, where we expect many hospitals to lose their eligibility, and perhaps will be make that more difficult for Congress to try to change the current law, because some of these facilities are now qualifying as rural, which has a lower dish threshold. It doesn't give you the same benefits that a full urban hospital gets when it comes to 340B discounts. For instance, no orphan drug discounts, but nonetheless, I think that will put a little bit of a wrench in momentum to potentially try to change that. That would be my uh, perspective. That the hospital is going to say we need to be able to have the flexibility here. So I don't know what will happen on it, but thank you for reporting on it, Will. And it was an interesting article that you wrote and an interesting piece in Health Affairs. So, and thank you for attending that event in Louisville and learning from so many of the rural hospitals on their perspective on this issue.
Yeah, absolutely. It's very interesting trends, and as you said, hospitals are getting hit by left and right by so many different things when it comes to 340B, Medicaid enrollment, potential Medicare cuts down the road in terms of Medicare reimbursement cuts specifically for 340B. So a lot happening there. And before we continue with this episode and get to your conversation with Colleen, Ted, we're just going to take a very quick moment to hear from one of our great sponsors.
Eliminate double payments, ensure compliance, and achieve unparalleled transparency with RX Paradigm's 340B Clearinghouse. Powered by the Tungsten Plus platform, RX Paradigm aligns seamlessly with stakeholders' needs, enabling covered entities to deliver cost-effective care while preventing double payments from drug manufacturers. With RX Paradigm's collaborative 340B Clearinghouse approach, double payment concerns no longer justify network restrictions. Unlock a streamlined, balanced 340B management solution for all parties. And discover efficient, optimized 340B management today with Tungsten Plus.
In today's episode, we're going to be joined by a very special guest to take some time to honor the incredible legacy of Sue Veer, who passed away earlier this week. Colleen Meiman, who worked at the National Association of Community Health Centers for many years and is now a senior policy advisor to state primary care associations, was a close friend and colleague of Sue's, and she joins us now. Colleen, thanks so much for joining us during this difficult time.
Absolutely. I am thrilled to see that Sue's legacy is getting the attention it deserves. She was a 1 in a million person, easily.
Colleen, tell me a little bit more about Sue's background. I always know her as the person who was omnipresent in the 340B advocacy and education field at all the conferences and involved in a lot of groups. But tell us a little bit more. She has a very interesting personal story about how she got involved in healthcare policy. Why don't you begin with that and tell us again where she worked, etc.
You mean you don't want to hear about her exploits at Woodstock?
Oh, gosh, I didn't know about that.
There are
That
some
sounds
very
really cool.
interesting stories about Woodstock. She quit high school to go to Woodstock, ended up getting her GED, which is pretty funny for somebody who then went on to get an MBA. But anyway, we'll skip past that part.
We'll have to do that in our next episode of the podcast when we start our music tribute, which will be our third podcast of that we have of our many podcasts. But to go back, Colleen, tell us more about, I know she has an incredibly interesting and powerful personal story, and tell us where she ended up after that amazing story.
Sure. Well, Sue and her husband were in a Bible college. I think it was called Toccoa College, but it was near Toccoa Falls in, I want to say Georgia, might be North Carolina. And they had a 2-year-old daughter named Jamie. And one night, due to human error, the gigantic dam holding up the falls broke. And it utterly, in a matter of seconds in the middle of the night while people were in bed, flooded the town, the college campus, the married student housing. Sue's, her daughter Jamie did not make it. In fact, her name is still listed on a stone marker they have near the site of the where the dam broke. So she lost her 2-year-old daughter. Sue survived, but she was the most seriously injured of all the people who survived that night. There were many who did not survive. She spent, I think, 2 months in the hospital afterwards and came out of it a fierce advocate for patients, because she had really experienced what it was like to be on the other side. So she worked for a while at UPMC, University of Pittsburgh Medical Center, and eventually made her way down to South Carolina, where she started out working at the State Association of Community Health Centers, the PCA, and eventually went to become CEO of the Carolina Health Centers, about 20 some years ago now.
Well, that's quite a elevation in a short period, and also one that is probably the most powerful story I've heard about why someone has gotten involved in the healthcare advocacy world. Really personal story. I personally knew Sue for many years and didn't find out until yesterday about this harrowing story of courage and overcoming a tremendous adversity on a personal level, and I was really struck by it. So I know she was really loved by many different people. Can you tell us a little bit more about her role in the 340B space? I think of her as someone who was involved in so many different organizations, and basically she never turned down an opportunity to get involved and try to help. So tell us a little bit more about some of the things she did on the 340B side.
She was omnipresent. Sometimes I joke, like, are you sure there's only one of you? You haven't been cloned? I know back when I was still a Fed, so this would have been like the early 2010s, she formed the first 340B work group among community health centers. And we used to joke, she used to tell the story, the first meeting she ever called had 5 people. Yeah. And of course, within about a decade, it was like we couldn't find a room big enough to put people in. I met Sue in 2015 when I moved to NAC. And remind me, I want to talk some about her incredible devotion to her children and grandchildren as well. But she was initially, when NAC was really ramping up its efforts to provide more support around 340B to community health centers, she and a few other people helped write the first NAC manual for 340B. We got some funding for state trainings, and she went to, I think, 20 some states and trained all their health centers on 340B compliance and good stewardship and all those sorts of things. She was integral in the start of the 340B grantee conferences. She, for years, planned the 340B or the health center sessions at the 340B coalition conferences. She has been one of the founding members and on the steering committee of the 340B working table, which has been working to find multi-party consensus on 340B federal legislation. And she testified before Congress, I think 2 or 3 times on 340B, and then at least once on other issues. And then clearly she didn't have enough to do besides running a health center. So she became secretary of NAC's board about 3-4 years ago, maybe 3 years ago now. So, but whenever you had a question, she was the person you called. Like you may recall, I was supposed to speak on one of your webinars. back in June, and I had something come up. I couldn't make it. And I don't think I even called and told her. I just said, Ted, call Sue. She'll cover for me. You know,
Yeah, yeah.
and of course she did. And I think I eventually told her I voluntold her. But she was just, and the other thing that doesn't have a title that goes with it, she brought up so many more junior people to be leaders, and not just on 340B, on other issues too. But she, found more junior staff in the health center movement and taught them, okay, here's how to get yourself a seat at the big kids table. Here's how you make the case for pharmacy. She was a mentor to so many people in the health center movement.
Yeah, well, that's a great story. Tell us a little bit more about her personal life. She had children and grandchildren. I know she liked to sail as well. That's my understanding. Tell us, you wanted to talk a little bit about her devotion to her family.
Absolutely. She lost the one child, but she has three, a son and two daughters, and I think around 12 grandchildren. I honestly kind of lost count. I mean, some who are ready to graduate college and some who are younger. We first met or we first connected because I have a child with autism and she is a grandchild with autism. And we just, she wanted suggestions on how to be the best possible, most supportive, loving grandmother she could be, and how to understand her grandchild's needs. So a regular attendee at gymnastic events and volleyball games. And as I said, she clearly figured out how to clone herself, because the woman, she claims she slept a normal amount, but I don't know. She was able to be so many places all the time that I sometimes I wonder if she really slept.
Yeah, and she's in the 340B space. I mean, she was one of those rare people who had great relationships with everyone, not only those on the provider side, but she got along well with the pharmaceutical industry folks and the government and lawmakers from both sides. Can you talk a little bit about that?
Oh, absolutely. I remember one time she was invited to go alone into a meeting of the pharma board of directors and explain 340B. And I know a lot of people would have been really intimidated. And she's like, well, they're CEOs and I'm a CEO. And yeah, there's a bit of a size difference here, but we have right on our side. We are using this program as it was intended. We are using this program to ensure that underserved populations get the health services they need, not just pharmaceuticals, but all of those services that they need. And she said, I have absolutely nothing to hide and a lot to learn from them, and they have a lot to learn from me. So I remember she went there and she had a lot of follow-up discussions with that group as well. She was in front of Congress several times. She was just sort of the straight shooter and the other thing is she had no tolerance for anybody who was not using the program according to the spirit of the law. I think we all know that there are ways that people on either side things that are officially legal but are not consistent with the spirit of the law. She had absolutely zero tolerance for that. This program was here to ensure access to care for underserved populations, and that's what she was going to make sure was done. And people recognized that about her. There was never a question of integrity or knowledge or anything else. So she could open pretty much any door she wanted and talk about this program. And didn't matter Democrat, Republican, whatever level of government, she was a trusted straight shooter.
Yeah, well, she will be dearly missed. I worked closely with her during my time at 340B Health. As you mentioned, she was very involved in with the health center breakout sessions at the 340B coalition meetings that we would co-host, and I know she was active in that to the end. So her legacy will be one that everyone was impacted by her, and I think that she will be remembered as someone who cared deeply about this program and someone who cared deeply about healthcare and vulnerable patient populations. She was a a real rock star, as I say. I want to thank you, Colleen, for your time, and I'm sorry for your loss, and I'm sorry for the loss of so many in the 340B community who knew her even better than I did. And you certainly, whenever I was at a conference, you seemed to be arm in arm with Sue, always talking policy, including in the middle of social events at a bar.
It wasn't always policy. I mean, we traded book records. She had lots of opinions on the guys I was dating.
Oh, that's funny. Oh, that's very funny. Okay. It seemed like you were talking policy, but I guess maybe that was just a front to make me think that you guys were deep in conversation about the future of this great program.
Yeah, well, all of the above. We would easily switch from one to the other because she was one of those people who was just really authentic. What you saw in person and who she was publicly, who she was professionally, who she was personally, it was all the same person. She's a real person of integrity. And so we would have no problem going from the 340B rebate model to, I really like that lipstick, but doesn't it dry your lips out?
Sure. Well, that's great. It sounds like she certainly knew how to have fun more than just focusing on what we like to talk about, the 340B program, but other aspects of society and culture. That's good news. Well, I want to thank you again, Colleen. Our condolences. Will, I also want to do a quick shout out to you. You had to put together a very detailed story about Sue with 24 hours notice, and you did just a terrific job in interviewing many stakeholders from both the provider side and former government folks, as well as people in industry. So thank you. Nice job, Will. I would encourage everyone to read his article about Sue in 340B Report.
Yeah, thanks, Ted. And I mean, given how close she was with so many colleagues and friends and the absolute outpouring of kind words and thoughts everyone was sending my way, it was that helped a lot. She had a lot of very, very, very deep and close friends and relationships. And no, it's impossible to put her legacy and what she means to so many people into words. But hopefully by including a lot of voices that captured just a little bit of the essence of how important she was.
Yeah, I've already received great feedback, and I knew, Colleen, you thought the article was quite special.
Yes, I really appreciated it. It's like all of us are drops in a pond or little rocks you drop in a pond, and some of us leave a couple ripples, and some people's ripples go out for miles and affect millions of people's lives they'll never even meet. And believe me, Sue left a whole lot of ripples.
Also, before we let you go, Colleen, I wanted to ask one more question because I've heard Sue was a very big foodie, and you might have some thoughts on that. Can you tell us a little more?
Oh, yes. No matter where she went, and she traveled all the time for work. Forgot to mention she was also like an advisor or leader for a group of retreats. But she would always find the best restaurants and post pictures and got to be like, and I'd be sitting at home eating something regular and she'd have this amazing meal and she was great. She could find the best food anywhere, no matter where she ended up.
Well, that's a good trait, and I think one that many in the 340B community share. So I think maybe she might be someone who is even more on top of it than some of us. But I think of myself as a pretty good foodie, so we'll have to talk about that one day, Colleen.
Check her Facebook sometime, but don't do it when you're hungry.
Okay, that sounds great. Colleen, I want to thank you so much for your time, and if you could pass our condolences to her family, that would be great. And perhaps maybe they can listen to this podcast when they get the opportunity. That will be helpful to them as they try to struggle with this difficult time.
Absolutely. I'll be down there this weekend. I will gladly pass them along. And yeah.
Okay, great. Thank you, Colleen. Take care.
Thank you.
And that brings us to the end of today's episode. We'll continue to keep an eye on all things 340B related and be back in 2 weeks with a new episode. Of course, we will report on anything that happens in the meantime on our website. Please follow along with our twice weekly newsletters. And just a reminder, if you're not currently a subscriber, you can take advantage of a 25% discount for first-time subscribers only by going to 340breport.com and clicking the subscribe button and using the code podcast25. And with that, I want to say thank you to Will, and we will all see you in 2 weeks.